Um, so yeah, hello everyone. Thank you for having us. I'm Danielle. I'm a pharmacist working in the implementation team, which is part of the Meds Access team at AWTTC. And Sabrina touched upon earlier that AWTTC has had a lot of newbies join the team, and I am one of them. So this is my first PAPIG meeting. I'm very excited to come here and present on one of our biggest projects that we've got within our team at the moment, which is Blueteq. And I'm here with my colleague Dave. Wondering if he wanted to introduce himself.
Yeah, hi. I'm not so much of a newbie, but I haven't been to a PAPIG meeting before either. I'm new into the implementation team, or relatively new, and supporting on all this work for Blueteq.
Thanks, Dave. So I'm going to take the first half of the presentation, which is running through what Blueteq is, giving you an introduction into the system, and then we'll pass over to Dave, where he'll talk about what does this mean in real life for practice and our patients. So if you don't mind going to the next slide, please. So really, what is Blueteq? So this is a web-based software system which is widely used within the NHS and is being used for roughly about 10 years in England, and is something that we are now trying and hopefully successfully adopting within NHS Wales. So the system consists of forms, so web-based forms that link to specialised treatments, which are what we consider high cost drugs and high cost medicines in use across Wales. So each one of these web-based forms is linked to an evidence-based recommendation from NICE or AWMSG, and the questions within the forms are, are reflections of these recommendations and completed on a per patient basis um, by a clinician for the patient who is going to receive treatment. And the way these questions are designed are they're mainly yes and no questions. Um, so if the clinician is answering yes to all of the questions, then the patient meets the recommendations for that medicine. So therefore, these forms are designed to be a prior approval for treatment. And our ambition is to have one form per treatment, and it's developed on a once for Wales approach so that everyone in Wales will be using the same form for that indication. Next slide, please. So where will Blueteq be used? So most specialist medicines are prescribed in secondary care services. Um, so therefore, the Blueteq system and implementation it will be rolled out for secondary care and being used by secondary care prescribers as well. So this is where it will be used in mainly outpatient settings or within the hospitals. Next slide, please. And who will be using it? So it won't be patients. This will all be going on in the background. So it's nice to know what's happening behind the scenes. So locally within health boards and trusts, it would mainly be specialist doctors, pharmacists, and nurses. It could also be a admin coordinator because there's functionality of the system as well to use to organise MDT clinics and follow-ups. And it will also be used by a nominated Blueteq lead for the health board. And these leads sit on the steering group, which I'll touch upon later. And then centrally, you've got the AWTTC Blueteq team managing the system centrally, and also we're feeding into the data team as well to see what we can pull out of the system and have real world outcomes and how these will benefit patients and clinicians going forward. Next slide, please, Dave. So the big question is, why is this system needed? So what are the benefits to patients? So really is to ensure that we get the right treatment to the right patients and the medicines are being used in an evidence-based way and as per evidence-based recommendations by NICE and AWMSG. And then because the forms are designed on a once for Wales approach, this is going to ensure that there is equitable treatment for our Welsh patients. and it's going to reduce the time taken to make these treatment decisions, which is also a benefit for patients in Wales. And then we do have major benefits for the NHS in Wales as well. So it's a tool to be able to manage the ever increasing complexities associated with prescribing these high cost medicines. There's a lot of tests now that might need to be, such as genomic testing, for example, that need to be carried out before a patient is prescribed the medicine, and this can be one of the uh, prior approval questions within the forms. And then because of the complexities of prescribing these medicines, we need to ensure that there is governance of this prescribing across Wales. And then another big benefit is these forms will provide indication-specific data of prescribing, which can feed back in to our commercial team, which manage the rebates of medicines on an all Wales level. So at the moment, there is a real lack of this indication split data in Wales, and there's not a electronic mechanism for capturing it. So at the moment, this is a manual task that health boards need to complete, and it's very time consuming to trawl through patients' paper-based notes and prescriptions to find that information and feed it back in centrally. So this will also free up um, pharmacy time to spend more time with the patients. Next slide, please, Dave. So when will it be in use? When does it come in? So it's really already here. It was split into two phases for rollout and implementation. And phase one was complete, is now complete. I think it's been complete for a couple of years. And this included all medicines that were commissioned by our NWJCC colleagues. This was roughly about 100 medicines, and this is slowly slowly going up as well, but they manage the very rare or rare disease areas. And phase two, which is what we are helping with, is all high cost medicines prescribed in secondary care. So the list that we started off with was roughly 600 medicines that we needed to develop forms for and make sure the system was ready for implementation. And we plan to have this completed by March 27 with implementation across all health boards and NHS trusts in Wales. So the governance of the system and rollout is overseen by the High Cost Drugs Steering Group, which has members from all health boards and trusts in Wales. Also has members from NWJCC to make sure that our work is consistent. DHCW, MVU, and I think that's everyone actually. And then, as I mentioned earlier, the AWTTC team manage the system centrally, and the steering group and ourselves oversee the process for reviewing and agreeing forms on a once for Wales approach, and we're in the process as well of managing the new appraisals that are coming out from NICE and how we develop those forms as well in a timely manner. Next slide, please. So a little bit more information on phase two. So as I touched upon, it's AWTTC managing the Blueteq system centrally. So what does that mean? It means that we are providing user training. So this is for super users, so that's the health board leads, or the users such as doctors, nurses, and pharmacists. We're drafting the forms and ensuring the process for review and sign off. And we as a team will have all historic forms, that's 600 medicines that I mentioned earlier. We're going to have forms completed for all of these by August 26. And then there will be a period between August 26 and March 27 where the health boards can fully implement these forms into practice. And then the Blueteq steering group oversees all of our work, and we also link and feed back into the commercial arrangement scheme for Wales Group as well. And next slide. So this slide really just demonstrates all of the recommendations that we've put together for our stakeholders. So our colleague and lead for implementation, Helen, has been to quite a lot of different groups to advocate for the implementation of Blueteq. So we reported to um, heads of pharmacy to make these recommendations for the implementation of Blueteq by March 27, and also for health boards to start thinking about the longevity of and upkeep of the system past this date as well. Next slide. And I'll just hand over to
So,
Dave for the second half. Thank you.
yeah, hi everyone. So yeah, I wanted to just give a little bit of context about where we're up to and also what information we can pull from the system beyond that basic number of form submissions and indication specific data, because there's other things that we can get from it which might be of benefit. Um, so this is where we're up to at the moment. We've got 8 disease areas which we've enabled for use on the system. Now this is moving very quickly, so if we did this again next week, there'd probably be more. This is driven by some collaborative effort with health boards, if there's and a special local need to develop some of these areas, or because some of these, like oncology, for example, there's lots and lots of high cost drugs which see a lot of use. So there's a need to get the governance and financial governance of those medicines as quickly as possible. Just to caveat that, health boards are in various stages of implementation with these, so they're not necessarily available across Wales at the moment. So the reporting functionality, there is the basic information for indication-specific data. Just to give some examples of those high-cost oncology drugs, some of them have plus 30 different indications. As Danielle said, that is a lot of labour-intensive work to get all that data and to provide that. Whereas with Blueteq, we'll be able to pull a report, split it up by indication-specific using each form, and it becomes a very easy task and frees up a lot of time. Beyond that, there's lots of things that we can put onto the forms around outcomes, medicine switches, baseline scores for various different conditions versus review scores. So, for example, the Severe Asthma Network have gone all in on creating very complicated forms which gather a lot of information on the patients, and they're going to use that to build a national registry of severe asthma patients, which brings us into line with what's happening in NHS England. But other areas as well, so weight management and rheumatology. Um, the migraine forms have questions built in, so we can look at treatment pathways within that disease area and see what medicines have been tried and failed for patients before they start a new one. So it's all useful information that clinicians can use to help inform practice and feed back into best practice patient care. To just dive into the severe asthma example, this is some of the top level information that we can pull out from the system. So this is total number of patients split by health board, and also split in new patients. So we have historic patients which have been onboarded onto the system when they're already taking a severe asthma medication, and then also patients which have newly been given these medicines and newly prescribed them since the system has gone live. One of the things that severe asthma are looking at is, have we discussed it in an MDT session? That's information that's useful to them. So again, that's an example of something we can pull out. The severe asthma forms they have lots of interesting things on there around exacerbation rates, number of hospital visits, emergency department visits, smoking status, whether patients have particular allergies. Unfortunately, we haven't got the data on that ready yet, because a lot of that relies on the patients going for a full cycle on the Blueteq system, which is a 12-month review. Because this has only been live since around January time, we don't have data to show yet on a lot of these outcomes and comparing baseline versus current. So yeah, unfortunately, we can't go too deeply into that. But what I can show you, just as an example, again, is this is looking at the severe asthma patients, what they started on, which biologic they started on, and then upon review, did they switch medication? So this graph, if we look at this first biologic, people who started on benralizumab, there's around 160 odd of them. 35 of them have had a review, and of those, 8 have switched. And we can see which medicines they've switched to. The forms also contain details of why they made that switch. So what was the problem with the first biologic? And then when they go to their next review, we'll be able to look at the progress they've made on the biologic they've switched to. So all of that is useful information, again, to help them with their care. Um, yeah, I think that's about it. As I say, we do have more information on the forms, but it's unfortunately too early to go too deeply into all of the outcome data and the comparisons that we will be able to do. But hopefully that gives you an idea of the possibilities behind the system and how it can benefit patients beyond that primary use of financial governance of high cost drugs. Sabrina?
Yeah, hi, Dave. I just wanted to ask about why it's called Blueteq, or what the actual form, what's the background to that? And just to comment that I think it's a real benefit having worked in medicine technology appraisal. A lot of when we make a recommendation, it's, for a specific group of patients who maybe have a certain characteristic. And actually what these forms help us do is really make sure that we're using medicines for the right patients and for according to the recommendations we made. So it really, really is very robust in making sure, because that's something before we had these forms we weren't really able to do. We put a lot of detail into deciding which patients we would recommend a medicine for, and we looked at the um trial data and lots of that, real detail. So this is such a fantastic step forward, where we're actually really looking at which patients will benefit, and that we can measure that it is being used in the right patients. So it's, brilliant is just my comment. But yeah, just to ask about the Blueteq, where the name comes from.
I have no idea. You'd have to ask Blueteq themselves. It's probably something
Yeah.
they came up with in a dark room somewhere after a lot of consultation. But I can show you what the forms look like. I do have one more slide
Oh,
just
that'd
on
be
that
brilliant.
because I guess we've talked about all these numbers and charts and forms and things like that. So just to give, this is what it would look like for the user who's filling out the form. And this is one of the more simple forms that we do have. But once you get onto a system, once you're set up, just to make the point that it's not a huge amount of extra work required in order to fill these out. So the patient details will auto-populate. You have to add patients separately, but we're working on a solution to speed that up as well and make that talk to Welsh Clinical Portal. So that step will be hopefully really smooth and quick for users. Then you add your own details, your prescriber details, but then most of the questions are simple yes, no, whether it matches the NICE criteria. So it takes less than a minute probably to fill this form out once you've done it a couple of times. This is an example of some of the, oops.
Dave, I can't actually read the questions. Would you be able to read out what some of those questions are?
Yeah, so question one, this is a form for idiopathic pulmonary fibrosis. So question one is just confirming that the patient is 18 or over and has that condition, just to match the NICE criteria. Also on the NICE criteria, it will specify that they have to have a forced vital capacity between 50 and 80%. That's what that box is about. So all that we need to do on the form is have yes to that answer. But what we can do is have this text box here, which asks the user to input the exact number. So then we can use that for data collection. And then on the review form for this specific indication, you will put in the current figure at that point as well, and then you'll be able to have a comparison. So just to show you what it looks like and hopefully make everything make more sense.